Welcome to our first video on infections of the respiratory tract. Before we discuss individual topics, let's first discuss what comprises upper and lower respiratory infections. The upper respiratory tract infections include the common cold, sinusitis, pharyngitis, epiglottitis, acute laryngotracheitis, and influenza. The lower respiratory tract infections include bronchitis, bronchiolitis, pneumonia, lung abscess, influenza, and tuberculosis. Note that influenza is both a disease of upper and lower respiratory tract. We have already discussed pharyngitis, epiglottitis, acute laryngotracheitis, bronchiolitis, and tuberculosis in other lectures. Here we discuss the rest of these topics. So in this video, we'll go through the common cold, sinusitis, bronchitis, influenza. Let's start with common cold. Common cold is the most common respiratory infection and is characterized by inflammation of the nasal mucosa and nasopharynx. It is caused by a viral infection, with rhinovirus being the most common cause. Other less common causative agents include coronavirus, respiratory syncytial virus, adenovirus, and influenza virus. The peak occurrence is seen in fall and spring. It's usually a mild, self-limited illness, characterized by rhinorrhea, which means nasal discharge, nasal congestion, which occurs due to inflammatory edema, and sneezing, which occurs due to nasal mucosal irritation. Mild pharyngitis and cough may also be present. Of note, common cold usually has a gradual onset, as opposed to the abrupt onset seen in influenza. Also, fever is uncommon, and there is usually only mild systemic upset. Again, as opposed to a high-grade fever and prominent systemic upset seen in influenza. The diagnosis is usually made on clinical presentation, so it's a clinical diagnosis. The infection resolves on its own in a few days. Nasal decongestants and antihistamines is provided during this time to help reduce symptoms. Next, we'll discuss sinusitis. Sinusitis is the inflammation or infection of the paranasal sinuses, which include maxillary, frontal, ethmoid, and sphenoid sinuses. Maxillary sinus is the most common sinus involved, one important reason being its drainage against gravity. Viral sinusitis is the most common form of sinusitis. Bacterial sinusitis usually occurs as a superimposed infection on viral sinusitis. The most common bacterial pathogens are Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. The inflamed sinus produces pain and pressure sensation, as well as tenderness over the affected sinus. For example, maxillary sinusitis produces tenderness over the maxillary area, while frontal sinusitis produces frontal headache. In addition, if chronic, the continued inflammation and consequent mucosal regeneration may produce polyps in the sinus. Sinusitis is generally a clinical diagnosis. However, to confirm, an X-ray or CT scan of paranasal sinuses can be done. This is particularly helpful to confirm and evaluate chronic sinusitis. On imaging, sinusitis is seen as thickness of sinus mucosa with a fluid level. Polyps will also be seen if present. Here is a CT image of a person with maxillary sinusitis. Note the opacification of the right maxillary sinus. Also note the area of radiolucency around the right tooth that is circled in red, which suggests the extension of infection from periodontal area into the maxillary sinus. Coming to treatment. When sinusitis is acute with viral etiology, treatment is supportive, including analgesics and decongestants. However, when bacterial sinusitis is suspected, antibiotics are indicated, most commonly combination amoxicillin clavulanate. Complications of sinusitis include facial deformity, which may occur due to enlargement of polyps, as well as spread of infection to other structures such as orbits, brain, and cavernous sinuses, giving rise to orbital cellulitis, brain abscess, and cavernous sinus thrombosis, respectively. Let's do a review question. A 19-year-old girl presents to the office with complaints of persistent headache and morning vomiting for 2 days. She's had nasal congestion, nasal discharge, and sore throat for 10 days. Temperature is 102 degrees Fahrenheit. Palpation elicits tenderness in maxillary areas. What is the best next investigation to perform? So this is a 19-year-old girl with complaints of persistent headache and morning vomiting for the past 2 days. These signs of high intracranial pressure, together with her prolonged history of nasal congestion, nasal discharge, and sore throat for the past 10 days, high-grade fever of 102 degrees Fahrenheit, and tenderness in maxillary areas on examination, are concerning for extension of infection from maxillary sinus to the brain. So this patient has a maxillary sinusitis, which is now complicated by a brain abscess. The investigation we will perform next will be brain imaging, preferably a CT scan to look for intracranial spread of infection. So the answer here would be CT scan of the brain and sinuses. Now we'll discuss the lower respiratory tract infections, starting with bronchitis. Bronchitis is the inflammation of the bronchi. It's most commonly caused by viruses such as influenza virus, parainfluenza virus, and RSV. Bacterial pathogens such as Streptococcus pneumoniae can also be responsible, as well as environmental irritants. For example, the chronic bronchitis of smokers. The inflammation in bronchi leads to cough with sputum production. Concurrent upper respiratory symptoms such as rhinorrhea may also be present, particularly if bronchitis is preceded by a viral upper respiratory infection. It's usually treated by supportive care, for example, antitussives and analgesics. Antibiotics are indicated if bacterial causes are suspected. Now let's discuss influenza. During our discussion on influenza, we'll go through its general features, clinical features, complications, diagnosis, treatment, and prevention. Alright, so influenza is caused by influenza virus. It has its peak occurrence in winter. It can affect both upper and lower respiratory tract. It's highly contagious, producing epidemics and pandemics. Coming to the clinical features. After an incubation period of 1 to 5 days, it presents with abrupt onset of fever and prominent systemic symptoms such as headache, malaise, and myalgias. Upper respiratory symptoms such as rhinorrhea, sore throat, and dry cough are also common. In most patients, it's a self-limited illness, which resolves in 1 week. However, it can have a complicated course and high mortality in selected patients, as we're just about to discuss in the next slide. So there's a number of complications that can occur in influenza. Some of them are even life-threatening. Hence, it's important to identify patients who are at high risk of these complications. The risk of complications is increased in older adults age 65 or above, in immunosuppressed individuals, pregnant women, and patients with chronic diseases such as diabetes, mellitus, and renal failure. These individuals need special attention in terms of both treatment and prevention as compared to the general population, which we'll discuss in a while. So what are the most important complications of influenza? Secondary bacterial pneumonia is the most common complication. The viral cytopathic effect on respiratory mucosa makes it vulnerable to attack by bacterial pathogens, making it easy to catch pneumonia. The most common bacterial pathogens are Staphylococcus aureus and Streptococcus pneumonia. Secondary bacterial pneumonia post-influenza is characterized by worsening of symptoms after an initial improvement. Influenza virus can also directly cause a viral pneumonia. Hence, another common complication of influenza is a primary influenza pneumonia. This also manifests clinically as a sudden worsening of symptoms such as increasing cough and appearance of dyspnea, which marks the involvement of lower respiratory tract. The rest of the clinical course is similar to a viral pneumonia, including characteristic interstitial pneumonia on chest X-ray. Other complications of influenza include influenza encephalitis and worsening of asthma. Based on these clinical features, influenza is generally a clinical diagnosis. However, for confirmation, various tests can be used, including rapid influenza test, as well as more definitive tests such as reverse transcriptase PCR or viral culture by taking a nasopharyngeal or throat swab. In addition, chest X-ray is done whenever there is clinical suspicion of pneumonia. Similar to other viral respiratory tract infections, the usual treatment is supportive, which includes bed rest, fluids, analgesics, and antipyretics. Antiviral agents, such as oseltamivir, are indicated in all patients with increased risk of complications, irrespective of the duration of illness. This reduces the incidence of different influenza complications in these patients. Antiviral agents are also beneficial if given within 48 hours of symptom onset in low-risk patients, because if given this early, it reduces the duration of illness. Antiviral agents are also used to treat primary influenza pneumonia. For prevention, annual influenza vaccine should be administered to everyone above 6 months of age. Secondly, isolation of affected individuals by giving sick leaves, for example, is also beneficial in reducing spread of influenza. Let's do a review question. A 67-year-old, previously healthy male presents to the office with complaints of fever, headache, and malaise for the past week. He also had rhinorrhea and sore throat initially, which improved with rest and analgesics, as advised by his family physician. I felt like I was getting better, but my condition has taken a turn for the worse since yesterday, he says. He is now complaining of worsening fatigue and fever along with cough and shortness of breath. Temperature is 101 degrees Fahrenheit. Blood pressure is 100/70. Pulse is 115. Respiratory rate is 26. Rapid influenza antigen test is positive. In addition to bed rest, fluids, and medications, what further investigation is most likely indicated? So this is a 67-year-old patient who is experiencing flu-like symptoms including fever, headache, and malaise for the past week. He also had rhinorrhea and sore throat initially, which improved with rest and analgesics. This patient's upper respiratory tract symptoms, which improved with supportive therapy, is typical for viral respiratory illness. Moreover, his prominent systemic upset makes influenza the most likely diagnosis. However, despite getting better initially, his symptoms have suddenly gotten worse, and he's now complaining of worsening fatigue and fever, along with cough and shortness of breath. Temperature is 101 degrees Fahrenheit, blood pressure 100/70, pulse is 115, and respiratory rate of 26. This sudden worsening of symptoms and appearance of lower respiratory tract symptoms and tachypnea is concerning for possible pneumonia in this patient, which is the most common complication of influenza. Rapid influenza antigen test is positive, confirming influenza, and so appropriate treatment in the form of rest, fluids, and medications will be given. Additionally, a chest x-ray will need to be performed in order to evaluate for pneumonia in this patient. So the answer would be chest x-ray. Lastly, let's discuss lung abscess. Lung abscess can occur directly as a result of aspiration of oropharyngeal contents as part of aspiration pneumonia, or it can occur as a complication of typical bacterial pneumonia, most commonly by Staphylococcus aureus, Klebsiella, and Pseudomonas. It has an indolent onset, presenting over days with fever, rigor, productive cough, night sweats, and weight loss. Chest x-ray shows a cavitary lesion with an air fluid level. Treatment includes clindamycin and ampicillin. Postural drainage of abscess can also be helpful. This image is showing the typical cavitary lesion of a lung abscess with an air fluid level. Let's do a board-style question. A 56-year-old male presents to the clinic with complaints of fever, chills, and rigor for the past 2 weeks, associated with dyspnea and cough, productive of foul-smelling sputum. He also reports weight loss. Medical history is significant for hypertension, ischemic cardiomyopathy, and bipolar disorder. Medications include lisinopril, rosuvastatin, aspirin, amiodarone, and lithium. He does not smoke, but drinks 5 to 6 cans of beer daily. His temperature is 100 degrees Fahrenheit, blood pressure is 140/85, pulse is 98, and respiratory rate is 24. Chest auscultation reveals coarse breath sounds in the right lower lobe. Chest x-ray shows a cavitary lesion with an air fluid level in the lower zone of this right lung. Which of the following is most likely predispose the patient to his current condition? A. Hypertension, B. Amiodarone, C. Alcohol use, or D. Bipolar disorder. So this is a 56-year-old male with complaints of fever, chills, and rigor for 2 weeks. He also reports dyspnea, cough, productive of foul-smelling sputum, and weight loss. These symptoms of dyspnea and cough help localize the patient's infection to the respiratory tract. Moving on, his medical history includes hypertension, ischemic cardiomyopathy, and bipolar disorder. Medications include lisinopril, rosuvastatin, aspirin, amiodarone, and lithium. He drinks 5 to 6 cans of beer daily. Temperature is 100 degrees Fahrenheit, blood pressure is 140/85, pulse is 98, and respiratory rate is 24. Chest auscultation reveals coarse breath sounds in the right lower lobe. The constellation of his respiratory symptoms, their indolent onset, his alcohol use, and examination findings of consolidation in the right lower lobe make lung abscess the likely diagnosis. This is further confirmed by chest x-ray finding of cavitary lesion with an air fluid level in the lower zone of the right lung. A lung abscess most commonly occurs due to aspiration of oropharyngeal contents, and the most likely predisposing factor in this patient is his alcohol use. Hence, the correct answer is option C, alcohol use. Here is a slide reminding us of lung abscess. Now let's discuss why other options are wrong. Although hypertension and ischemic cardiomyopathy is associated with congestive heart failure and can cause dyspnea and cough, other findings of congestive heart failure would be present. In addition, fever and foul-smelling sputum would be absent, so A is wrong. Amiodarone use is associated with pulmonary fibrosis, which presents with progressive dyspnea and dry cough, and chest x-ray finding of bilateral interstitial infiltrates, all of which is absent in this patient. So B is also wrong. D is wrong because bipolar disorder is not associated with lung abscess. And this concludes our section.